Right. I'm going to pause here and invite Ann up and encourage you to please ask any questions that you like. The broader, the better. Usually it's hard to get too specific in an individual child, but broader questions would be even more helpful, I think, for the whole group.
So we're going to go around again and take your questions. I just want to remind you at the very end of this session to sit for a minute. I have some important announcements that you need to hear.
Sure. Question was regarding Todd's paresis, and do you want to talk? So Todd's paresis was described by this guy named George Todd years ago as an English neurologist, and what he noticed was that after a seizure, an area of your body could be weaker than usual. So if you had an intense seizure, say for example, I had an intense seizure involving my right arm with stiffening and a lot of clonic activity, and it lasted a long time, I might be weak on that side. And so in a child, how would you see that? Usually it's diminished spontaneous movement. So if I was moving, I would just be relatively inactive in that one arm. I'd move the other arm and do things, but I'd reach across and try and grab for things with my contralateral arm. Todd described it in people who had underlying focal structural lesions, which is not always the case in pediatrics. But one thing that would go through our mind if someone had a persistent Todd's would be, is there some other explanation why they're getting a weakness persistently on one side? And we want to probably, in that case, consider imaging and see if there's some other explanation. It's a good question. Yep.
I want to thank you. This has been the best breakdown of seizure types and descriptions I've ever had before. I've read a lot, but sometimes in reading online, things are left out or you can't really fill in some of the blanks. So I want to thank you so much for being so specific and breaking all this down.
Oh, thank you.
My question is this. I don't know if you hit on what's been going on with my son for the last 14 years that nobody can seem to figure out, and there's other Angelman individuals that have these same type of seizures. He's had the monitoring and had 2 or 3 of these events, and they say these are not seizures, they don't show up on the EEG, and my question is, what are they? And I don't ever get a good answer. It's been called myoclonus.
Cortical myoclonus.
Yeah, and he goes into status. They have lasted as long as 8 hours, and we give him benzos, and sometimes all they do is just kind of smute him and slow him down, but he keeps on going. He's UPD 25, has always been mobile, active, can run, goes up and down stairs without any help, and just mobility-wise, he's very good. But when he gets these seizures, he cannot walk very well, sometimes cannot really walk at all. He can't physically tell himself, his brain can't communicate how to move effectively. So most of the time we make him lay on the bed and he's shaking and tremoring, but he's fully conscious. We can keep him immobile most of the time by just watching a movie. If it's not a movie and it's a show, when a commercial comes on, he's reaching for the remote, change the channel because he hates commercials. He can sometimes eat.
Let him get to the question.
Okay. He can sometimes eat. But anyway, I want to know, do you know anything about these? And we just cannot we can't get rid of them. We can't make them even, get more than 2 days in between the events.
I think it would probably be really helpful to look at a video of those events. It would be very helpful for us to see a video of those. Maybe we could take a look with you. But it could be a couple of things going on. One is, like with this long period of altered responsiveness, there would be a concern. Could that be non-convulsive status punctuated by some myoclonia? And that's a possibility. The second is, you're getting at is, well, does myoclonia that's epileptic always show up on the scalp? And the answer is no. So you could have epileptic myoclonia that's not having a consistent EEG correlate, particularly if it's not widespread. some tricks that you can use. The doctors can, while they're simultaneously recording from the scalp, put non-invasive surface electrodes on the muscle groups involved. And then you can look to see carefully, do the twitches of the muscle correlate with anything on the EEG? And do a kind of pinpoint co-registration of those to see, oh, actually it does. It always lands on the sharp component of that slow wave. So yeah, it does look like it has a correlate. So sometimes there are little tricks like that that we'll use. But I think we should, maybe we could look at the video and see, but that would be one concern. You might be describing some epochs of non-convulsive status.
We also at times will add additional electrodes on the head too. It's called the 10-10 system, or a modification of that, along with these electrodes over the muscles. So together that can sometimes help. But it would be interesting and a good idea to look at the video if you have it.
Yeah.
Okay, so it's a question over here and then back to here.
Thank you so much, Dr. Anderson and Dr. Nordley. We have a lot of people that are watching that aren't in the room, and even here in the room, we have a lot of newly diagnosed parents that are here. Can you explain the importance of having a baseline EEG once you get the diagnosis of Angelman syndrome, even if your child is not seizing at that time?
Yeah, and I think, I mean, apropos of our comment about this and about trying to look at subtle changes in behavior. So, you know, we're hinting about and talking about non-convulsive status, and we mentioned, we didn't go into detail, that there are at least 3 different types of patterns that as EEGers we'll see in children with Angelman syndrome. And these may be characterized by highly rhythmic backgrounds, which is what your background might look like when you're in non-convulsive status. So one aspect would be having a good comparison of like, what do you look like normally, and then you have that for future reference if, heaven forbid, you ever need a reference point. The other is really important. As you're going along in the treatment, you know, with a child, you're always concerned, like, what is the impact of the seizures on their development? What's the impact of the drugs? Sometimes that's hard to sort out, and there the EEG can sometimes be helpful. So the EEG will change sometimes in a predictable way in response to medication. So if let's say a child has been doing well and then there's some deterioration, it's helpful to have an EEG to look and see, is that because there's a lot of seizure activity? Is that because of non-convulsive status? Or is the background deteriorated? Have I attenuated it because of too much medication? So that kind of comparison would be very helpful as well. So that's a good point.
Okay, over here.
Hello, thank you so much for being here, and I really want to thank the entire community. We are newly diagnosed, and it has been the support of all the people that has gotten us through. So I have 3 kind of generic questions. The first one is, how do I figure out what seizures? So you asked the question, have we seen these seizures? Maybe I've seen all, and maybe I've seen none. I have no idea.
Yeah.
Right? And is there anything you have seen which we can kind of put in at home or some? You know, I've seen a lot in the ECG's case, smaller devices at home, you can detect something. Have you seen anything of that sort which can help us detect things? The second question is, what is the treatment? In the sense, why treat them? Based on what you discussed, most of them don't seem dangerous, so why treat them at all? And the third one is, you also mentioned that certain drugs are more popular in Europe versus US. What is the reason of the popularity in one region versus the other?
Mm-hmm. Really good questions. And do you want to tackle any of them?
Well,
I'm going to jot it down.
regarding, the first question is how do you identify the seizures? And there are a number of techniques that our patients use. There isn't, or at least not widely used and not used in our clinical population of patients with Angelman and other disorders associated with seizures, is any kind of home monitoring. But you can keep a log of behavioral events that you see, and that's something you can take with you to your neurologist. And I think then based on that log, a decision can be made about longer term EEG monitoring to try to capture those events and then define them as to whether or not they're seizures. Now the caveat, of course, is what we heard from the parent over here about these myoclonic events that have been recorded in the epilepsy monitoring unit and have been described as non-epileptic based on the interpreter. But for the most part, I think the events would be captured, and if they're epileptic, that will show up on the EEG. So I think keeping a log and then bringing that to your neurologist and moving forward from there with their recommendations.
I would agree, and don't worry about it. I mean, it's got to be overwhelming. I presented a lot of stuff, but over time, you know, we often quip and say parents are the best seizure detection device, you know, that over time, parents and I have a particular bias for maternal grandmothers. Those, they're amazing usually. Nothing against paternal grandmothers, but maternal grandmothers, so in any event, over time, you know, you'll know your child's repertoire better than anyone. And my purpose was just to try to help familiarize you with the terms neurologists use so you can attach the terms to what you're seeing. I find what's really helpful in my clinical practice is when people come with their phones and they say, I saw something. I say, well, what was it? And they said, you mind, you know, they're always sheepish, like, do you mind if I show it to you on my phone? I'm like, bring it on, it's great, you know. And do you find that too, Annie?
Absolutely.
And then, you know, you say like, well, that's the event. And it's like, oh, that's myoclonus. Oh, you know, that could have been an atypical absence. And then over time, you'll build the connection. And then as Anne's saying, sometimes it might require a video EEG study to say, okay, this is this and that is that. And then you'll have a nice, you know, solid vocabulary so you can, like she's saying, you have a log of events and you can quickly communicate what it is that you're seeing. So don't worry, I'm sure you'll come to speed, and with God, there's so much expertise here that people can help along that process. Reason for treatment is an excellent question. Sometimes I wonder that myself. There might be though two important things, like two of the most important things. One would be to protect against prolonged convulsions, like we were talking about. And you could say, but Doug, why don't we just use rescue medication? But you could find that you're using rescue medication too often, which is not good for the developing brain to keep hitting with multiple, you know, doses of benzodiazepines, for example. On the other hand, the other reason for treatment might be if seizures were so frequent, say for example atypical absence, you might not be able to learn and process. But your point is an excellent one. It might not be worth chasing after every little myoclonia. It might be that the cumulative effect of medicine is worse than the seizure. So it could be that at some point you want to say, no, I'm not going to, you know, push that hard because on balance, I think my child's better. We always say, like, our goal is no seizures, you know, with no side effects. But with a symptomatic epilepsy, lots of times there may be some compromise in that. So it's a really good point. And don't be sheepish about talking to the neurologist about saying, like, I don't agree with, you know, too much medication. I think we want to protect against certain seizure types, but maybe there's some discussion about all.
So can you just clarify that, though? There are some seizure types that you would want to treat.
Yes.
And others that you might be able to
Exactly.
to decide. So
Exactly.
which ones should you absolutely treat?
I think, man, I mean, probably would be, if you were to ask most epileptologists, we would say convulsive seizures, whether they're focal with secondary convulsive elements or primary convulsive seizures. Probably I would put also atypical absence in that.
I would too.
Right?
Yeah, absolutely.
Not necessarily all myoclonia. Maybe it's worth trying to suppress some myoclonia. Focal seizures, what if it was a teeny tiny focal seizure? So one other thing, medications tend to work like a chemical corral. So they get the biggest seizures first, then the intermediate seizures, and the last ones they snuff out are the smallest ones. So it could be you have a little tiny focal seizure, or maybe it's just an aura. That might not be worth chasing after, because in order to snuff that out, you may have to go to very high levels of medication. So it's a really good point that you're raising. And the third thing is regional differences. Do you want to talk about that?
In medication use, well, part of it is the medications that are approved, FDA approved, and also the timing of approval. If we've been using it longer than the European and the Australian groups, then we have more experience with that particular agent. So that may be preferred because we've used it in these children and we know in these certain seizure types it works. Whereas in another country, they had other agents available earlier on and have more experience with those. So that's I think part of the underlying reason why they're regional in terms of different parts of the world. And you may have
I completely
other
agree.
points to add.
Okay, so we have a lot of questions. We're going to go back and forth. If you can keep your questions to the point, we might be able to get more of them in before lunch. So, okay, Sharon, yours.
Yeah, I have a question. My son has the reflex epilepsy, so he can have 50 to 100 a day of these, and I haven't heard you touch on that at all. I don't know if that's common in Angelman syndrome, but putting his shoes on, brushing his teeth,
Yeah.
any type of stress, but he's on a lot of meds, but nothing hits him. And they do turn up on his EEG. I mean, we can trigger them. So I just wanted to see what your thoughts were on that.
Yeah, I think that can be a very problematic type of seizure. I've had difficulty with my patients as well with reflex seizures. A couple of things, some broader spectrum agents sometimes tend to work better. Valproate is one, probably you've tried, that many authors in different countries say could be helpful in reflex seizures. One thing that I've tried, and I don't know if this is apropos, is I had a patient of mine who had reflex seizures in association particularly with eating. So, and I was getting the sense that it was responsive to Depakote, to valproate. So what we did is, since it was highly predictable when that child was going to eat, is I gave a slight booster dose of Depakine 20 minutes before, and that markedly improved the reflex seizures. So I don't know if it's all the time or if it's certain epochs of the day. If you could anticipate that and instead give something short acting right around that time to give a little extra edge of protection rather than bathing the brain in lots of medication throughout the whole day. I don't know if that's helpful. But that can be a challenging seizure type to deal with.
Yeah, I don't have anything to add. I haven't seen it that much with this population, but with other genetic disorders like Rett syndrome or the boys who have the Rett mutation.
Yeah.
So.
Yeah, it's a good point. Ernst Niedermeyer pointed out in Rett syndrome that just tapping of the contralateral finger pulp would increase epileptiform discharges.
Okay, and I didn't mean to panic anyone. We have an hour. I just want to get all of your questions in.
You turn it off, you turn it on, right?
Thank you again for your time today. This is a really amazing discussion here. First question, I was wondering if you had an opinion as to, based on the type of seizure, which medication would you recommend? And I'm specifically interested in atonic, but maybe some other people can get some benefit. The second question that I have is, I'm told that Angelman syndrome has a specific EEG pattern, and I was wondering, in extreme layman's terms, if you could maybe explain a little bit about what that looks like and what that's all about.
Sure.
And then just was wondering, our daughter, for example, has the UBE3A mutation, and we were told that that the seizures are a little bit less severe, but in your experience, depending on the phenotype of Angelman syndrome, are there specific types that you see? She looks like atonic, but maybe there's some, I just was wondering if based on phenotype you see specific types of seizure activity too. And then lastly, we were wondering if you have ever considered providing anti-seizure meds prior to a clinical seizure. Our neurologist has done that, and it seems to have staved off a lot of her seizure activity, but I don't know if that's ever been done, in Chicago or even recommended. Thank you.
With regard to atonic seizures, there are a number of different agents. I can't honestly say which I would a priori say would work the best for any individual. It's kind of a list of things that we would try. And there was a study, not specific to children with Angelman syndrome, but looking at in LGS in general and saying, okay, in LGS, if you were to take all seizure types and do a meta-analysis of different medications, which one tended to be better? And it was in that particular, to the degree you could extrapolate, it was topiramate for the tonic seizures, lamotrigine for the atypical absence, and felbmate for the drops. Now, I don't know how much experience there's been with felbmate. Has anyone been on felbmate? Okay, just a few. So that was singled out within the LGS. One of the reasons for why many people may not have been on felbamate is that there's a 1 in 7,000 chance of an of a life-threatening liver or bone marrow problem. The bone marrow problem doesn't occur less than 13 years of age, or at least it hasn't been reported, but the liver problem still does. So we're all, as clinicians, kind of frightened of using that, and it's usually relegated lower down. One thing we didn't talk about, and I don't have any, honestly, experience about, is VNS. And one of the indications for VNS is for atonic seizures. May I ask again, anyone here have any of your children have a VNS, and if so, would you mind sharing experiences? Yep.
For us, it was a lifesaver, and so she went from having 20 to 25 minute, up to 40-minute tonic-clonic seizures every 4 or 5 days to 1 or 2 a month that lasted maybe 1 or 2 minutes.
Wow.
So she gets diastat about once or twice a year. It may go on to 5 minutes, but I think it saved her life. I really do.
Was she having at the same time any drop attacks or any?
Well, no, that was my question, is that
Yeah.
we've gone all this time now, she's 25, and she just started having these drop attacks. These, they were, before then, they were all just, grand mal, just typical,
Yeah.
What you would think. And our neurologist, I live in Lexington, Kentucky, and I don't think he sees very many people with it. And she's had 3 of these, but they've been 6 months apart, And his sort of thing is, if we can't get an EEG, that was my question. She's 25 years old, she's stronger than me. How do you get an EEG in that situation? But his sort of thing is, if it's only happening every few months, just leave things the way they are. So, but she still takes Klonopin, and then, and after about a year on the VNS, she started having more frequent, so she was on Depakote, but for about 11 years, she hasn't had any change in her medication with, very few life-threatening, no life-threatening seizures, but shorter ones.
Well, given that she already has the VNS, maybe, I don't know, have you tried talking with him about making adjustments in the VNS? Changing the cycle?
We were just there and in June, and he wasn't interested in changing anything, as long as, you're talking about chasing seizures. I mean, our I guess, level is sort of like, thank God she's not dying,
Yeah, gotcha. Ann, you're probably more knowledgeable than me about genotype, phenotype.
Yeah, I've searched for genotype, phenotype studies in Angelman syndrome, clinical studies, and I have not seen any good ones. So in terms of the seizures and the EEG findings. So I'm not aware that exists there. I know that Carlos Bacina at our institution is collecting EEG data and clinical, and of course has genotype data. So I might ask him and find out, because if he's not planning to do it, maybe we could work together to use his data to do it. The Angelman EEG it's usually very abnormal, particularly when they do come to the lab, because in most cases it's because they've had a suspected seizure or have epilepsy. And I remember the first time as a faculty, I had to read those studies without any other backup from my mentors who had trained me. And one of our experts in this area, as well as Rett syndrome, is Dan Glaze, and he mostly does sleep, but he's a great electroencephalographer. And he does sleep right next door to where we're reading EEGs. So I would see these studies and I'm like, Dan, help me, because your eyes just cross. There's so much rhythmic, slow activity, and it's mixed with spikes. But like Doug said, it's not a typical absence pattern, and it goes on. And then do you read it as a seizure? Is this And so I got a lot of coaching and a lot of mentorship from Dr. Glaze in terms of reading the studies, and now I'm very comfortable with it. But there's a lot of epileptiform activity, which is sharp waves or spikes. They're exactly what they sound like. They're these high amplitude, spiky looking waveforms, and those are mixed in with this rhythmic slow activity. And typically you don't see a lot of the normal patterns that you would see in a child that age. Usually there's a posterior dominant rhythm that comes out when they close their eyes, and then an anterior posterior gradient to the EEG. At times, that rhythmic, slow, and chaotic background activity can suppress, and you might see glimpses of this normal activity or semi-normal activity, but it's usually quite distinctive. I did see an EEG earlier this week, in a patient with Angelman syndrome who was in our adult epilepsy monitoring unit for suspected seizures, who was 33 years old. And I'd never seen an adult Angelman syndrome EEG. And interestingly, her EEG, it pretty much had a normal background activity. And there was a lot of artifact, because I think what you're talking about, she was strong, like your daughter, and not that cooperative, but they did get her hooked up, and in the EMU, the electrodes are actually glued on, so, it's harder to pull them off. And she had some frontal spikes and slow waves, but it was not anything like what you see in the younger child. And I think it would be interesting to know how many of you have adult Angelman children, and whether they've had recent EEGs, because we know with, say, Rett syndrome, for example, those girls have very abnormal EEGs when they're young, and then they tend to normalize and become different in adulthood. And it would be interesting to know if there's a maturation to the EEG that we see in Angelman as well. Does anyone have adult, and they've had EEGs?
Mm-hmm.
Did the seizures come back when they did that? Okay. Oh, yeah.
So to kind of summarize what Ann was just saying, in general, with patients who have what we call epileptogenic encephalopathies, there's two features. The background is slow, and there's multifocal spikes. What's unique about children with Angelman's is, as Ann was saying, you get rhythmic slowing, and it's called notched delta. Usually there's a consistent relationship to the spike to the slow wave, but in Angelman's there isn't. So you'll see the slow wave, and the spike could be at any different portion, in the front, at the top, on the aftergoing portion of it. And so that has a very distinctive EEG pattern. So much so, like Christian Korf and Kent and I wrote an article, like just blindly reading EEGs. When you see that, like you were mentioning, Anne, you could say, is this child delayed? And then, and then tell me about their tone and so forth. And you can highly suspect the diagnosis just by reading the EEG once you're aware of that kind of EEG pattern. Now, you had a question about the anti-seizure medication before?
The neurologist who diagnosed our daughter had noticed that she was murmuring a lot, and we were told at the time by other families that was a precursor to having full onset clinical seizures, as she called them. She said that our daughter was showing 4-second bursts of activity on her EEG, and that she'd never done it before, but because of the high percentage of seizures, she agreed to put our daughter on the Keppra, and her tremors immediately stopped. And we think, for the most part, they've been well controlled, the seizure activity too. So I don't know if you have ever done that or considered it before, and what your thoughts are there.
I think it's one of these times, particularly when you're dealing with subtle seizures, where the EEG can be really helpful, and that marriage of the EEG and the clinical is very important. Generally our response is treat the patient, not the EEG, but sometimes you need to consider both. Yeah. Yeah. Usually we don't. Like absence seizures, infantile spasms are two prime examples where we treat the EEG, But there are circumstances like what you're describing where it's a good idea. And I think that parenthetically was the was one of the things that advanced pediatric neurology, epileptology, is when the same people who were reading the EEGs saw the patients and started putting the two together. I think that was really helpful.
Got one over here. Oh.
Hi, I was wondering if the drop seizures happen just as frequently at night as they do during the day, and then if they only last a few seconds, are you able to pick them up from an EEG? Because our son has had several, and at night when he's asleep, he kind of jerks, but he'll start to roll his head down and then he'll jerk. But they've said that they show nothing on the EEG, so that's it.
Usually deep sleep is protective. Like if you get beyond stage 2 sleep, you know, so sleep goes like, you get drowsy, that's light, stage 1 sleep, and then you go into stage 2 sleep. That's about 30 minutes. That's the highest likelihood time period when you're gonna see seizures, is those first 20 minutes or so of sleep. Once you get into deep sleep, that might last, say, like another hour or so for a full 90-minute cycle, that deep sleep is very protective, so you don't tend to see seizures then. But of course, the cycle repeats itself several times normally in the course of a night. So every time when you're in that stage 2 sleep, you're vulnerable. The only way probably to answer that, since you're not going to be, standing in a sleep, so the only way you would see it is by using EMG electrodes. And what the doctors would have to do is correlate the characteristic EEG discharges with the polygraphic signal to be sure. But my guess is probably not. Probably, most of the time, when you're awake, if you have those kind of electrodecrements, you're at risk for either myoclonia or drops. And if you're asleep, it would be more tonic types of seizures. So I would say probably not. You probably don't have to worry about atonic seizures in the middle of the night.
Hello. Sorry, just going back a few minutes, the woman in the front corner that has the young man, 25, I actually do have a video of the young man I work with in one of those states with me, just for you to see. Okay. On purpose. Okay. Because we are experiencing the same thing, and these muscle contractions and relaxations we have seen last between 8 and 9 hours at times. We are now treating them when they start with 8 milligrams of Ativan, and we're having them end in about an hour and a half. So that's sort of been our success rate. When he finishes the episode, it's like someone turned on a light switch. It just stops, boom, suddenly.
Wow.
Yeah. And he's 26 now. He seems very aware through it, like the lady at the front there. I'm sorry, I haven't met her, and I am going to chase her down later. Hello. Like the episodes, we lay him on a bed, we dim the lights, we put on a movie, and he watches something. Seems that he can answer some sort of yes/no questions during it. He's not able to walk or move, and his body rhythmically contracts and relaxes. We've also heard from doctors this is not seizure activity. Also with what is it?
If he falls asleep, would the
he
movement
does
stop?
not sleep. He does not sleep through it. No. No. And after you would think anyone else after 8 milligrams of Ativan would be knocked completely out.
Yes.
He's quite alert. He's quite active after. And he might stay up, like if this happened in the morning, he'll stay up the remainder of the day.
Wow.
He takes Ativan orally. He's able to.
We put it under his tongue. We soften it with a bit of liquid and hold it under his tongue. Actually, in the last 6 months, we've just gone through the training to give it to him injections. And with the injections, if I'm available to come in at my workplace when they call, I can give him 4 milligrams and bring him out in an hour and a half. So we've been able to reduce the dose by half if we use injections.
Yeah.
But I have the video.
Okay. We'll take a look. Yeah.
Good.
Can I just comment on that? This is a very common thing that we're hearing in our community when kids start to go through puberty and they're adults. It's very common, and I think we've been told it's cortical myoclonus, that it's not seizures. Since 2001, I've seen a young man who's about 14. His arm will start doing this, and he'll actually tuck it under his other arm and try to make it stop.
To suppress it. There's a fancy-dancy way to answer this. If the EEG doesn't, it's a technique called back averaging. It's not universally available. You sound Canadian? Are you? You are? So you know, I don't know if like, where are you in Ontario or? North of Toronto. So I was wondering if Toronto might have somebody who can do back averaging, but it would be, so back averaging is a technique where you put electrodes on the muscle group and you record the myoclonia. You simultaneously record the signal on the scalp. So even if you're not seeing it with the naked eye, you take all of these individual jerks and you summate them and average them, and then you can figure out, is it cortical, subcortical, or brainstem or spinal myoclonus. So there is a way to get a definitive answer. If you don't have access to that fancy dancy machinery, it might be just trying a number of measures to see if it's suppressible and looking at it carefully and trying to see if it looks epileptic or not. But yeah, they're great. Yeah, and they couldn't crack it. And they're,
we actually threw him into one and it still didn't show really activity.
mm-hmm.
We're hearing the term dystonia.
Well, it doesn't sound dystonic from what you're illustrating, and that's a really good team of doctors that's in Toronto. So, well, let's take a look at the video and see what we can come up with. Maybe we'll promise to stick around and we can look at it, and that we should continue.
Over here. I just have a couple questions that are all bundled together into probably one answer. So my son just turned 5 and had some atonic seizures before, but the neurologist recommended we hold off, and then he had a grand mal and started him on Keppra. So my question is, or questions, do they get quote unquote worse as our kids get older? Do they grow out of them, so to speak? And if they're controlled on medication, how do we know when to take them off, if to take them off medication at all? And also I was told that sometimes there are seizures occurring that we don't even notice, so is there a recommended amount of EEGs to get for our kids? So that's all bundled kind of together. And then the last thing is, we all know that illness and sleep deprivation can trigger seizures in our kiddos. So my question is, we know they don't require as much sleep, so I kind of feel helpless about that. And he might get 5 hours and I'm like, oh God, he needs 10 or else he's gonna start having seizures. I mean, what's kind of the correlation, and is there any recommendation for that? And thank you.
Well, I guess in terms of the recommended number of EEGs, I think, again, it gets back to this point of we treat the patient or the child and not the EEG. And if your child's doing well, I can't see that you would need to keep bringing him in for EEGs. I know a lot of our clinicians at Texas Children's Hospital, that they will get an EEG in the epileptic patients once a year. Is that necessary if the child's doing well? I'm not sure, especially for a child where they're not going to be so cooperative with the study, and it's kind of traumatic. So I think thinking about treating the child and not the EEG. So I would say they probably don't need one unless you're going to think about changing the medication. These are symptomatic epilepsies, so it's much less likely that they're going to grow out of the epilepsy. The seizures may modulate, say we just heard with puberty. They seem to get worse, and that's not just with Angelman syndrome, it's with all sorts of different epilepsies, even with children who we don't have any defined genetic abnormality, that they will get worse with puberty because there's modulation with the sex hormones. So, I think it's difficult to know if your child's not having any seizures and has gone 2 years like that, and the EEG's not showing active seizure activity, whether or not to taper the dose or let the child outgrow the dose is another option. But just given that we know they have the genetic mutation, have already had seizures, it's, I think given the right stressors, your child would be very much at risk to have another seizure. So,
I agree with everything Ann was saying. I think, in general, you know, if you take somebody who doesn't have a symptomatic epilepsy, you know, we used to call primary idiopathic. Our general rule of thumb is once you've been seizure-free for 1 or 2 years, we would consider stopping the medicine. I'll sometimes recommend going longer in people who've had symptomatic epilepsy regardless of the cause, just figuring that if someone's in remission, just give it a little bit longer so that the brain can do what it can do to decrease excitability, which it has a capacity to do over time. And one of the markers that you can use on the EEG is the epileptiform activity. So we've been talking about how much epileptiform activity there is. If you see that resolve and go away, that's a very good sign. So if epileptiform activity were to disappear and the child's seizure-free, then those would be 2 good indicators to say, okay, it might be an appropriate time to wean medication. Triggers, it sounds like you're doing the best you can. I mean, everybody's variable into how much sleep you need, so you can't say that, you know, this child should have 10 hours. Some people don't need 10 hours. And I guess you would know, the way we would know, we ask is there excessive daytime somnolence? If there isn't, if someone doesn't look excessively sleepy during the day, then they're probably getting enough sleep. And then the best thing is not so much the total hours, but the routine. Just try to keep the routine as consistent as you can, because it's that disruption of the routine that seems more provocative rather than necessarily the total number of hours. So, but don't beat yourself up. There's just so much a human being can do in terms of controlling all these variables.
Okay, we're here.
Hi, thank you so much for being here and giving us this opportunity to ask questions. My question centers around tremor that I'm seeing in my daughter. She is 7 years old, deletion positive, and based on what you described, it looks like she's having the focal seizures with maybe the secondary generalized tonic-clonic. She's being treated with valproic and Lamictal. And with the Lamictal, we've seen an increase in her tremor. Mm-hmm. And I'm just wondering, how do you treat that? Do you, I mean, I'm assuming that you just kind of play around with dosages?
You can, and it could be a dynamic interaction between the Lamictal and the Depakote as well. Depakote of all of our drugs is one of the ones that we know at certain levels will start to introduce a tremor, and there's a lot of interaction between Depakote and lamotrigine. If it's due to that interaction, and Depakote is playing a contributing role to it, sometimes giving L-carnitine will help. It chelates the intermediaries like the 4-deltaine and other metabolites of valproate, and so supplementing with carnitine might be helpful in reducing the tremor. There was a Hungarian study that looked into that, and they said that supplementation with carnitine did reduce tremor. If you don't like giving pills, it's avocados is extremely high in carnitine.
Oh,
Yeah.
Interesting.
Yeah.
That's good to know.
Yeah.
Also, you mentioned the aura associated with the focal seizure. Do you see that in any other types?
No, generally speaking, no. There is, so an aura is that specific sensation right before the seizure, so it'll come right before. There's another thing that we call a warning, meaning that some people with generalized seizures can wake up and say, I think this is going to be a bad day. You know, they just have like a non-specific warning that something's not right, and then sure enough, later on in that day, they have a convulsion. But that's not an aura. An aura comes right at the start of the focal seizure.
What I see in my daughter is she'll reach out, and she has this look of like panic and fear on her face.
Yeah.
Her pupils are fully dilated,
Yes.
kind of glossy-eyed,
Yeah.
and then we also get the seizure scream either like before or after.
Mm-hmm. Yes, that does sound like an aura.
And sometimes ictal vomiting associated with it as well.
Yes,
Okay.
yeah. One of the EEG types we didn't talk about was occipital predominance of the spikes, and if the seizure tends to involve the occipital region, that might be one of the common correlates to is ictal vomiting.
Got it. Thank you very much.
Got one over here.
Good morning. Thank you so much for doing this, and you are an amazing, great speaker. I think we're all getting a lot of information out of it. I do have one concern. On the FAST website, it stated that there was going to be information on CBDs as a treatment for seizures and all of this good stuff. I haven't heard anything on it. I am, of course, a big advocate for it. Don't see anything listed up there, so I'm a little bit disappointed in that area. So I would like to know your opinion, your experience on it. Do you have any suggestions as using it as a preventative measure towards my son. My son's 2.5, recently diagnosed. Sorry, I get.
It's okay. Yeah.
And we are giving it to him preventatively, hoping he doesn't get seizures, because all of this seizure medicine talking is freaking me out.
Yeah.
Because my husband has seizures, and I do not want to see that for my son.
Well, thank you for that. Ann and I were talking about the CBD thing, and it's, you're not alone in that. I would say, like, probably, do you find this too, Ann? Maybe one of the commonest questions people ask me, usually after a little while, usually they're like, you know, they're kind of looking around. CBD is there's two components in medical marijuana. There's THC, which is the part that, you know, people recreationally use it for, and then there's CBD, which is the cannabinoid, which is the component that may have anti-epileptic or anti-seizure effect. It's so you may know that it's extremely popularized right now. There's a lot of encouragement. People are very excited about it. At our place, so I work just like a 10-minute walk away. We have an ongoing study that's not yet published, so I can't publicly release what the results are. But my colleagues Christine Angia and Linda Lux are doing a CBD trial through a pharmaceutical company, and so we will be getting there, finishing up an open label phase right now and moving into a double-blind placebo. Only thing I would say about that is be careful about all the hype that's out there. Until you have a chance to see the scientific evidence, just keep a wary eye. And I know it's frightening when we start talking about all these side effects of medicine. I mean, I've been prescribing them for 30 years. No one hates them more than I do. But in the right situation, at the right doses, they can be extremely helpful. So they're not always terrible. They can, used well, they can be very beneficial. And the dietary treatments as well, which we didn't really talk about much. But so I understand the reason. It seems natural. It seems like, wow, this may be something promising that has been neglected because of, you know, other reasons. But the only thing I can say is I wouldn't recommend you move shop and go to some place that has medical marijuana on that. Wait a little bit. The results will be out. And then you can judge for yourself. What do you think is the scientific rationale? We're on the same side that you are. If we're eager to find anything that might be helpful in the care of children, because we are upset as well at all the things that we see, and particularly if you do this for a while, like I have for Ann for a quarter of a century, it's wearing. You don't like seeing those things, but at the same time, we have to be balanced and kind of rational about what we do, because things can have pretty pronounced consequences. So it's just putting out a word of caution. Like, I know it's exciting, cautious.
Well, I've seen it work.
Yeah.
I've seen it in multiple different applications. So I'll still be honest with you. I am very disappointed you're not touching on it more, because it was on the website as though it was going to be a topic of discussion, and again, I don't see anything here, and I understand that possibly you're funded by these larger companies, and maybe that might be not be as a big thing, but I've also found out that, and researched it, when they do put it into a pharmaceutical pill and do the fake things, people die when they synthesize it. It horrible effects on people, and so, again, I'll be honest, the main reason why I'm here is because I was hoping that I was going to get some sort of additional information on this one subject. That is why I'm here.
Oh, okay. May I just say two things about, I'm not supported by any of those pharmaceutical companies that you're on there. My only conflict of interest is that my group is running this trial for a company that's doing the CBD, so if anything, we're probably biased in the same direction. But as far as, I mean, we can certainly discuss it. There's plenty of interesting things. There's a lot of CBD receptors in the brain. There's been signals from epidemiologic studies. So if you have specific questions about it, we'll be happy to answer them.
Okay, so
yes.
You said that it's the pharmaceutical company that's producing the CBD for your study.
Yes.
Are they taking the one component, or are they taking whole plant CBD and using that in that treatment study?
So this is a synthesized compound of just the CBD. One could extract it from a plant, as you know, and then you could extract it with certain varying amounts of THC and see what the result of that is. So please don't misunderstand. I want to dampen your enthusiasm for it. I'm just saying that there are many things that over the course of centuries we've seen in epilepsy that we think looks promising, and then it's good to just have it subjected to the same kind of rigor as we do anything else in science.
So we've been neglecting the back of the room, so we're going to have two questions in the back, and then we'll start going back and forth.
My question is in determining which is the best medicine for my child to be on, or any child, and sort of, you start, stop, try this one, try this one. The epileptologist is recommending she be admitted to ICU, stop all meds, and just see what happens and go from there. I guess I'd like your thoughts about that approach to finding the right seizure med.
We do, in a monitored setting, like you're talking in the ICU, probably with EEG electrodes and continuous monitoring, at times stop gradually, very gradually, taper one medicine and then the next, and it would take, if your child's on several medications, it could take a while. And the half-life of various medications can be longer or shorter, so I don't know, it could take a while to get them all the way off their medication, and then a while for the seizures to evolve. I mean, that is one way that we do characterize seizures in certain patient populations, particularly the epilepsy patient that we're considering surgery for. Since I don't know all the details of her seizures and her medication history, I would have to defer to her epileptologist, but I would definitely be, if you're going to do that, it should be under the care of an epileptologist who's going to be taking the history and reviewing all the previous history and medication treatment, and then reading the EEG and defining the seizures. It can be dangerous because children, perhaps like yours, when they're off all medications, they're very much at risk for going into continuous seizure activity, so status epilepticus, and it's dangerous, especially if it's a generalized seizure. So you need to have a very good plan for rescue and stay very much on top of that. And when we're doing this sort of thing in a high-risk child like that, we would have at the bedside the Ativan or the diazepam, and then we would have other medications like phosphenotoin or the Keppra or the Depicon. All of that would be right there, so we're not waiting for pharmacy, because I think the big risk is a continuous seizure that's very much difficult to break.
Okay, so what we're going to start doing is going from this side to the back to Sharon and around. No, they're next.
Okay, she's been waiting there.
Well, you were back.
Thank you. I have an 8-year-old son, and this last summer he developed what my doctor called stomach migraines or stomach seizures, where he starts vomiting and it can last up to 8 hours. And we finally got it under control with cyproheptadine, I think that's what it's called.
Yeah.
So it stops the vomiting after about 3 hours, but during the whole time he's throwing himself down on the ground. We cannot console him, we cannot hold him down. We just have to let him puke all over the house as we chase him, trying to control it. So I'm wondering, what kind of a seizure is that actually? And are we just controlling the vomiting? Is he still having the seizures? Is there another med we should be trying instead?
If it's responding to cyproheptadine, which is periactin, it sounds like it might be more of a migraine equivalent. The periactin won't have much of an impact on a seizure itself, but it's a very old but well-respected treatment for migraine. It's an antihistamine, and so it's very gentle, but it can be very effective for migraine or migraine-like attacks. Do these occur in cycles, like, or they're just sporadic?
They were sporadic for about 2 years. It didn't happen that often. And then this summer, it was just one after another, like every other day, constantly. And then when we got him on this, then it only happened twice since we got him on this.
Okay.
He's only on 2 milligrams of it, but it would just be sporadic. We'd use
Yeah.
the first store and all of a sudden it just started happening. And then Zofran couldn't stop it.
Mm-hmm.
It's the only thing we could get to him. He takes it every single morning.
Has he had an EEG, video EEG during the episodes?
No. So it's kind of hard to predict when it's going to happen.
Yeah. There any other manifestations aside from vomiting, like eye deviation or stiffening or jerking?
Yeah, he stiffens up, he jerks, he throws himself on the ground, and if you even try to hug him or anything, he just completely stiffens just like this, and I can't pick him up. He can barely move him when it's happening. And you could just see it, he's scared. He just has this terror look on his face of what's going on, I don't understand.
What other medications is he on?
He's on 10 milligrams of risperidol, a 0.1 milligram of clonidine ER, another 0.1 milligram of regular clonidine, and then 2 milligrams of the cyproheptadine.
It might be helpful to get an EEG, even just an interictal EEG, and see see what the brain wave activity looks like, and if there's a lot of epileptiform activity, or I mean that might be a starting place for the neurologist, and then move forward from there.
Okay. Thank you so much. I appreciate it.
Sure.
Okay, Sharon, and then in the back.
Hi, we have a daughter that's deletion positive. She's 3.5 years old. She has had 2 tonic-clonic seizures. They were all on the same day. At that time, they put her on Keppra, and that has been, over a year. My question is, well, it seems that you think that it is safer to keep them on meds. So even if she never has another seizure again, we should probably keep her on meds for the rest of her life. And your opinion on, as far as the Keppra on liver toxicity and versus one of these diets, do you think one is better than the other?
So there were 2 convulsions in one day?
Yes.
That's a tough one because some people will say that so the definition, like a practical definition, one practical definition of epilepsy is to say you had 2 or more unprovoked seizures, or one seizure with a high likelihood of a recurrence based on the underlying cause. So either way, you could say that that's meeting the definition of epilepsy. But there's a caveat. The epidemiologist will tell you that if you have your 2 seizures on one day, that's pretty much like 1 seizure. So you're in a gray zone where you'd say, well, in a symptomatic epilepsy with 1 for sure seizure, it's a high likelihood you might get another one, but at what point? Is that a week? Is it a month? Is it a year? Is it 2 years? We don't know. So this is a gray zone where there's not really an absolute right or wrong answer, and I think it's a really good thing to discuss with your doctor about that. Having said that, the risks of levetiracetam, I mean, it's been around for a while. It's one of the more widely used medications. So unlike some of the others that we have on the list, it doesn't have as bad of a side effect profile. So the risks are not very high at all from that medication. So it's a gray zone.
Do you just recommend like the ketogenic and the LTG diet on more severe cases?
Well, it's not irrational to think about it in other circumstances, but by and large, practically, yes. It's usually after, a medication has failed that we'll consider that. One could take exception that Eric Kossoff has raised that and said, why not try primary treatment of that? We do for certain forms of symptomatic epilepsy like GLUT1, but generally speaking, that's right. It's not usually the first choice. I mean, could be a point of discussion though.
And it's difficult to maintain if your child orally feeds. It's different if the child has a G-tube or is feeding, with formula. But if your child likes to, have a plate full of food and take what they like and what seems interesting to them, then you're going to limit their food choices if you're on a dietary treatment. So that's another issue that I see our patients go through when they're deciding to even try it.
Just as a follow-up to that, we did have an online question about LGIT, so I wondered if you had more you wanted to say about that before moving on to another question about its effectiveness.
Mm-hmm. Sure. The ketogenic, well, in general, dietary therapies like maybe the best known that we have is the ketogenic diet, which has been around for almost 100 years now. And so we use it quite extensively. It works very well in myoclonic epilepsies. While it seems onerous at first when you're first thinking about it, generally speaking, once you've gotten into it and learned the diet, it's really, most of the parents of the patients we treat with the diet end up saying it really wasn't all that hard. At any given point, we have about 175 children for a variety of reasons on ketogenic diet. So it just requires good supervision with a ketogenic dietitian, because there are certain things to look at. The LGI diet, in contrast, is using similar principles, but instead of, ketogenic diet is very high in fat, low in carbohydrates, a ratio typically of 3 parts of fat to 1 part non-fat, which is carbs and protein put together. The low glycemic index diet, it just tries to reduce the amount of high glycemic foods, and so to some extent is mimicking the same type of action of the ketogenic diet. And in studies that have been done of that, looking at LGI diet in various circumstances, looks promising. It's something that older people, like we will commonly, if we have younger children, we'll move towards more standard ketogenic diet, but for older children, adults, we may move to like a South Beach diet or low glycemic index diet as something that's more easily tolerable. Also, the brain's ability to extract ketone bodies varies as a function of age. So you can extract more ketone bodies when you're younger. So a very high ketogenic diet is probably something that, for physiologic reasons, is better tolerated when you're young.
Hi, I have 2 quick questions. So the first one, I'm curious if you have any insights into why it is that seizures tend to start right at around age 3. Sort of what happens in the development of the brain that might change at that time period that tends to onset seizures. And then the second question I have is curious to know if you have ever thought of or heard of any neurologists prescribing very low dose GABA reuptake inhibitors versus sort of the normal dosing levels of the same type of medicine.
Mm-hmm. Well, one of the, you're talking about tiagabine?
Yeah.
Yeah, I would be cautious. I mean, it's logical. It's a very logical mechanism of action that you're talking about, but we know from practical experience that tiagabine exacerbates myoclonic seizures. So, it's the funny thing. Like you'd say, mechanistically, it ought to work. Tiagabine makes perfect sense, but yet when you give tiagabine to people who have predisposition to myoclonic seizures, it exacerbates them. It was the same thing that we thought about we thought, oh, this is going to be the US version of vigabatrin for spasms, because, vigabatrin poisons the transaminase of GABA, so we thought, tiagabine's going to be perfect, and flop. So it's sometimes hard to go from the mechanism of action to predicting clinical efficacy.
Okay, thank you.
Yeah. Did you want to? Do you
Got
have
a question
comment
back
about
here?
the why at 3 or why before age 3? Yeah.
Just to comment on your point about why the seizures seem to manifest later after other symptoms of Angelman are evident, we don't know the specific answer for that, but part of it could relate to the fact that the brain is maturing, over those early periods, it's myelinating, and it may just be that at that point there are enough networks connected that now with the right stimulus, the seizures evolve and are more evident. There could have been seizures earlier on that were missed because they were so subtle. We know that there are delays in aspects of other genetic disorders. I mean, I think that Rett syndrome is one of the classic ones where early on you don't see the midline hand movements, and then there comes a point during that, around the first year of life or maybe earlier, when you start to see the loss of their hand function. And, you know, maybe also the molecular and biochemical abnormalities that are occurring with the deletion or mutated protein, then you know, at some point, especially as the brain develops and those molecular and biochemical pathways are changing, it reaches a point where there's now toxicity, or there's inflammation, or there are changes in critical molecular components of the synapse and the dendritic spines. And we already have evidence that in Angelman syndrome mouse models that there are abnormalities in those components and glutamate receptor partners and whatnot. So there may be some developmental evolution of that to the point that now you have this very seizure-prone brain, and that happens to be, you know, this late toddler stage.
Okay, so we're getting close to the end of the 2 hours. We're going to take a question over here and see where we are. Remember, I have back here and see where we are. I have some important announcements for you, so please don't leave until we get to the announcements.
I have a question. Our daughter has had, when her seizures have been severe, her lips turn blue, her hands and her feet turn cold and mottled, her SATs drop, she requires oxygen supplementation. Is that indicative of a certain type of seizure, and what's happening in the brain when that happens? Thank you.
I mean, that can happen in a variety of different seizures, but you know, I'd say the two contexts where you see it is after a convulsive seizure. You know, during a convulsive seizure, you'll get oxygen desaturation. After the convulsive seizure, the normal response is to take a big cleansing breath, like a sigh, and to resume respiration. Sometimes that is altered in the postictal period, and so you can see those kind of autonomic changes. But the other time period it can occur is with certain types of focal seizures, particularly ones that are getting in the region of the insula. So they can have these autonomic changes that occur, and that may be sometimes is a very prominent feature of certain focal seizures.
Do they happen often? How?
Yeah.
Yeah, sounds like a focal seizure.
Yeah, probably a focal seizure involving the right hemisphere and getting into the insular region. There's some people have wondered whether the right side more so than the left side is responsible for those kind of autonomic changes, but it's not all that well known. Clinically, those kind of that kind of pronounced autonomic change sometimes, oftentimes diminishes as people get older. So. Yes.
My question, because our daughter has this, is it, like, will she stop breathing? Because she turns blue as she clamps down.
Mm-hmm.
And the other thing is, our daughter actually went 3.5 years seizure-free, and then she had seizures. So it was 3.5 years of nothing, and and then all of a sudden it hit. So with the same medicine, nothing was stopped, but then it hit. So we adjusted her medicine, but just so you can go a while seizure-free, but the symptoms, even on medicine, can come back.
Mm-hmm. We touched on an important point, which is this very important point of SUDEP, or sudden unexpected death in epilepsy patients, which is a frightening topic, but something we're increasingly talking about, at least in the United States. I know it's a common topic. We're not exactly sure what all the parameters are about that, but it looks like, at least in the cases that have been recorded in adult units, it's mostly patients who've had convulsive seizures are left unattended, nobody's there, and they have a period of time where they desaturate, they're not breathing normally, and then ultimately their heart stops. That seems to be the sequence. We very rarely, touch wood, have seen this in a pediatric unit, and I think the reason why is parents are there. So I think the reason that we don't see this more is that it's probably, my guess, is not a primary cardiac thing, that it's more respiratory. And all the things that parents do when they, check on their child and they alert them, they are probably helping in that regard to kind of maintain their respiratory status and protect them. So I think that's not wasted time. It does not appear to be a phenomenon in the middle of a seizure. So it appears to be a phenomenon at the end of a seizure when the EEG is all completely attenuated. So I'd say, long story short, during that seizure, probably not. I mean, yep. Yep.
Because it's just so scary.
Yeah.
She has a heart condition, so.
Yeah.
Yeah.
Yeah. Yep. And so that's an important caveat. There might be circumstances where it is important. Usually the core oxygen desaturation is not, we don't believe is very profound at all. It's more the peripheral. So the lips and the fingers and so forth look bluer than really the core is of the brain and the internal organs. So usually, in most circumstances, we don't recommend people, administer oxygen at home because of the fire hazard and so forth, but there can be extenuating circumstances where that's very prudent to do. So it's a good thing to talk to the doctor about. Yeah.
Okay, so we're going to take the last question here.
Thank you so much for this. So we've got a daughter, her name is Annalise, she's deletion positive. And I've taken her, we've done a couple of EEGs. They only last for 30 minutes. They show this typical Angelman spikes. I don't know, there's a whole lot of scientific lingo in there, which I don't really understand. But bottom line is, apparently she doesn't have any seizures. But what I notice sometimes is like she'll have some kind of her head will just go to one side. When she wakes, or when she's sleeping, sometimes she'll just, as if she's startled, as if someone's startling her, she'll just sort of have that, only a couple of seconds. She did have that in the EEG. It didn't show anything abnormal about it, so I really don't understand. Now, I guess what my question is, let's just say that she is sort of having those subtle seizures. Is that going to lead to more dangerous seizures later on?
No, I don't think necessarily, and I think if you decided not to treat those, was that? I mean, I don't know the circumstances, but that sounds, from what you're describing, prudent. If they're very brief, they didn't have a correlate, they haven't progressed, I think that's perfectly reasonable, is observe those. Could it change? It's possible, but then you can always reconsider the decision to treat at that point. Yeah. So. Yeah. Don't know the question about should she a priori go on a diet.
I don't think so.
I don't think so.
And I would like to think you would reserve that for later on in case she develops more severe seizures that are refractory to the other agents that are easier to administer. Mm-hmm. And then at that time consider it. But and I don't know of any data that would support that,
No.
in clinical studies.
You sound Australian. So our Australian colleagues are also like some of the best in the business. They're really excellent child neurologists in Australia. So.
Yeah, and epileptologists.
Yeah, and epileptologists, yeah.
All right, let's thank our speakers for this really phenomenal.